When a celebrity is hospitalized, it's headline news. A photo outside the building, a statement from a publicist, a flood of well wishes trending by lunchtime. But for millions of Americans, the story was never really about the illness. It's about what shows up in the mail 6 weeks later. Here's the uncomfortable split nobody puts in the headline. A celebrity gets admitted, treated, stabilized, and discharged, and the story ends there. Because for them, financially, it basically does end there. For an ordinary family experiencing the exact same diagnosis, the exact same hospital stay, sometimes even the exact same building, the story is just getting started. The bill arrives, then the second bill, then a letter from a collections agency, then a decision about whether to pay the mortgage or pay the hospital this month. Same illness, same medical system, two completely different aftermaths, and the difference has almost nothing to do with the diagnosis. By the end of this video, you'll understand exactly why medical debt became a uniquely American problem, how insurance quietly reshapes the actual cost of getting sick, why wealth doesn't just buy better health care, but a fundamentally different relationship with the bill itself, and what any ordinary family can actually do about it before they ever need to. Let's set the scene, because this matters more right now than it has in decades. Medical debt is not a rare misfortune in the United States. It's closer to a routine outcome. Roughly 100 million adults in America carry some form of healthcare debt. That's not a fringe statistic about unlucky outliers. That's close to 40% of the entire adult population carrying debt that, in almost every other wealthy country on earth, simply wouldn't exist in the same form. And here's the number that should genuinely unsettle you. Medical debt is the single largest source of debt in collections in the entire country, larger than credit cards, larger than personal loans combined. Getting sick in America has become one of the most financially dangerous things that can happen to an otherwise responsible person. Compare that to nearly every peer nation. In countries with universal health care systems, a serious diagnosis is frightening for entirely medical reasons. In the U.S., it's frightening for medical reasons and financial ones simultaneously, stacked on top of each other, arriving at the exact moment a person has the least capacity to deal with either. So why does this happen here, specifically, when it largely doesn't happen elsewhere? Let's break down the mechanism, because the answer isn't simply health care is expensive. That's true, but it's not the whole story. The real story is about who actually ends up holding the bill, and why. Step 1. American healthcare doesn't really have prices in the way you'd expect. It has something closer to a negotiation conducted entirely without your involvement before you ever see a bill. Hospitals set an initial list price for every procedure, a number that's often wildly inflated compared to what almost anyone actually pays. Insurance companies then negotiate a discount off that list price, sometimes a very large one, in exchange for steering their members toward that hospital. Step 2. If you have insurance, you typically pay something closer to that negotiated rate, plus whatever your plan requires through deductibles, copays, and coinsurance. If you don't have insurance, or you're out of network, you're often billed closer to that original inflated list price, the one almost nobody actually pays in full. It's a strange inversion of how markets normally work. The people with the least financial cushion are frequently the ones facing the highest sticker price, because they lack the one thing that triggers the discount, a large institutional buyer negotiating on their behalf. Step 3. Even with insurance, most Americans are enrolled in high-deductible health plans, meaning they're responsible for the first several $1,000s of care before insurance meaningfully kicks in. A plan can be marketed as comprehensive coverage while still leaving a family fully exposed to the first $5,000, $6,000, $7,000 of any serious medical event, an amount that for a large share of American households exceeds their entire liquid savings. That's the quiet mechanism sitting underneath the whole system. Insurance was sold to the public as protection against catastrophe. In practice, for a huge number of people, it functions more like a discount card attached to a bill that still arrives large enough to cause real damage. Now here's the uncomfortable math, laid out plainly. More than half of U.S. adults report they couldn't cover an unexpected $400 expense using cash or its equivalent without borrowing or selling something. A single emergency room visit, even a routine one, frequently exceeds that amount before a single test gets run. A short hospital stay for something like appendicitis or a broken bone can run into the tens of thousands of dollars in list price terms, an amount that, spread across a household already living paycheck to paycheck, isn't just inconvenient. It's structurally unpayable without debt, without depleting retirement savings, or without simply not paying it and absorbing the consequences of collections instead. And collections consequences are real. Unpaid medical debt can damage credit scores, which raises the cost of car loans, mortgages, and even the security deposit on an apartment. So the financial damage from a single illness doesn't stay contained to the hospital bill. It ripples outward into every other part of a person's financial life for years afterward, quietly raising the cost of being alive in almost every other domain, long after the actual medical crisis has ended. Here's the irony sitting right in the middle of all of it. The system is technically designed with a safety net. Hospitals are legally required to stabilize emergency patients regardless of ability to pay. Nobody gets turned away from an emergency room mid-crisis for lack of insurance, but stabilization isn't the same as affordability. You will be treated. You will also, eventually, receive the bill for having been treated. And the law that guarantees your care says nothing about guaranteeing you can survive paying for it afterward. Now let's talk about how wealth changes this story, because this is where the gap between headline and reality becomes almost uncomfortable to look at directly. For someone with significant financial resources, none of the previous section applies in the same way. Not because they're charged different prices at the register. Technically, the negotiated rates are often similar, but because the entire relationship with the bill itself is different from the moment they walk in the door. A wealthy patient can afford concierge medicine, a model where, for an annual fee, a small number of patients get direct access to a physician who isn't juggling a caseload of thousands, meaning problems get caught earlier, appointments happen faster, and care coordination doesn't get lost between 6 different specialists who've never spoken to each other. Catching a problem early is, in itself, one of the most powerful financial advantages in medicine, because early treatment is almost always dramatically cheaper than treating something that's been allowed to progress. A wealthy patient can also simply absorb the deductible, the copay, the out-of-network gap without noticing much change in their daily life. $5,000 is a real number. It's also, for some people, roughly what they'd spend without a second thought on something else that month. The exact same bill that bankrupts one family barely registers as a line item for another, not because the bill is smaller, but because the person receiving it operates from a completely different financial floor. And there's a quieter advantage too, one rarely discussed. Wealthy patients are far more likely to have access to a financial advisor or family office that can negotiate medical bills on their behalf, dispute inflated charges, and navigate insurance appeals with actual expertise. The exact kind of administrative fight that overwhelms an average family already exhausted from managing an illness. The system rewards the ability to fight back against a bill almost as much as it rewards the ability to simply pay it. So the celebrity hospitalized and discharged by the weekend isn't experiencing a fundamentally different medical system. They're experiencing the exact same system, just from a financial position that absorbs its worst design flaws instead of being crushed by them. Here's where hype and reality really pull apart. The hype, repeated in insurance commercials and open enrollment brochures every year, is that having insurance means being protected, covered, safe. The marketing language implies a floor beneath you, a guarantee that illness won't become financial ruin. The reality visible in the collections data is that having insurance dramatically reduces your risk. It does not eliminate it. Underinsurance, meaning technically covered but still financially exposed through high deductibles and narrow networks, has become almost as significant a driver of medical debt as being uninsured outright. A person can do everything right, carry a job, carry a health plan, carry no history of financial irresponsibility, and still end up in collections over a single unlucky diagnosis, simply because the deductible on their plan was larger than their savings account.
Neither the insurance industry nor hospital billing departments are lying when they describe their systems as providing coverage. The problem is that coverage was never legally defined as affordability, and almost nobody discovers the difference between those two words until they're already holding the bill. Now zoom out, because the implications here extend well beyond any single hospital stay. Medical debt doesn't just burden individuals. It reshapes decisions across an entire economy. Studies have repeatedly shown that a meaningful share of Americans delay or avoid necessary medical care specifically because of cost concerns. Not because the care isn't available, but because the financial risk of finding out what's wrong feels as dangerous as the illness itself. That's an economy quietly encouraging its population to gamble with early detection, the one intervention that almost always makes conditions cheaper and more survivable to treat. There's a deeper irony sitting underneath that too. A healthcare system this expensive in a country this wealthy produces outcomes that, on several major measures, don't consistently outperform countries spending dramatically less per capita on healthcare overall. The extra cost isn't purchasing proportionally better population health. In large part, it's purchasing a more expensive, more complicated billing apparatus layered on top of the actual medicine. And the gap this creates compounds the same way financial gaps always compound. A family pushed into medical debt often delays other financial goals: retirement contributions, a child's education fund, a down payment, sometimes for years, while a wealthier family experiencing the identical diagnosis continues investing, saving, and building on schedule, completely undisturbed. The illness was equal. The financial trajectory afterward was not, and the two families may never even realize how far apart their outcomes actually became, since nobody sends a follow-up bill 5 years later, itemizing the opportunity cost. So what can an ordinary family actually take from all of this, beyond simply feeling uneasy about a system they didn't design and can't personally fix? A few things are genuinely within reach, and they matter more than they sound. Understanding that medical bills are negotiable is not common knowledge, but it's true, and it's one of the most underused pieces of financial leverage available to ordinary people. Hospitals routinely accept reduced settlements, particularly for uninsured or underinsured patients willing to ask in writing before the bill reaches collections. The list price was never really the price. It was an opening offer, and almost nobody realizes they're allowed to counter it. Understanding the difference between a plan's premium and its deductible before choosing a health plan, rather than discovering the gap during a crisis, changes which plan actually makes sense for a given household's risk tolerance and savings cushion. The cheapest monthly premium is not automatically the cheapest plan over a bad year. And building even a modest emergency fund, specifically earmarked for a health-related shock, separate from a general emergency fund, changes the entire decision tree during a crisis, from how do I avoid going bankrupt to how do I get the best care available, which is a fundamentally calmer, better decision-making position to make choices from. None of this fixes the underlying system. No amount of individual financial literacy changes the structural reality that getting sick in America carries a financial risk most peer nations simply designed away decades ago. But understanding exactly where the gap lives, between list price and negotiated price, between covered and affordable, between a family that can absorb a bill and one that gets buried by it, is the difference between being blindsided by the system and simply being unlucky within it. So here's the question worth sitting with, long after this video ends. If the exact same diagnosis can end one person's story at discharge and begin another person's financial crisis at the mailbox, what exactly are we actually measuring when we call a healthcare system successful?